This is the final talk in Unit 2, and it's where we bring everything together into practical strategy. We built the 2x2 table, calculated sensitivity, specificity, predictive values, and likelihood ratios, and understood how prevalence shapes everything. Now, the question is, how do you actually apply all of this when you're deciding which test to run, in what order, and what to do with the result? We're going to cover four interconnected topics. First, test sequencing, the strategy of using tests in series or parallel. Second, spectrum bias, why a test validated in one population can mislead you in another. Third, the consequences of misclassification, because false positives and false negatives have real cost that should drive your test strategy. And fourth, clinical prediction rules, structured tools that combine multiple inputs into a probability or risk estimate. Let's get into it. One test isn't enough, either because the stakes are too high, the test isn't perfect, or you need to balance sensitivity and specificity. You use multiple tests. There are two fundamental strategies, series and parallel. In series testing, you run tests sequentially. You run test 1 first. If it's positive, you run test 2. You only call the final result positive if both tests are positive. Think of it as a two-gate system. An animal has to pass through both gates to be classified as positive. The mathematical effect of series testing, overall specificity goes up, because to generate a false positive, both tests would have to be wrong in the same direction. That's less likely than either one being wrong alone. But overall sensitivity goes down, because to generate a true positive, both tests have to correctly identify the same truly diseased animal. The chance of missing the animal increases when you require both tests to fire. In parallel testing, you run both tests simultaneously and call any animal positive if either test is positive. Think of it as an OR gate. One positive is enough. The mathematical effect, overall sensitivity goes up, because a truly diseased animal only has to be caught by one of the two tests. But specificity goes down, because a false positive can come from either test, and now there are two opportunities to generate one. The clinical rule: use series testing to confirm. Use parallel testing to screen. And notice that this maps directly onto spin and snout. Confirmatory testing requires specificity. Screening testing requires sensitivity. Make series and parallel testing concrete with a real veterinary example. Testing beef cattle herds for bovine leukemia virus. Scenario A is herd certification. A producer wants to certify their herd as BLV negative to sell breeding stock. The critical error here is a false negative, certifying an infected animal as clean and shipping it to a new herd, introducing BLV unknowingly. So, we need a high specificity for our positive call and very high sensitivity for our negative call. We use the ELISA as a screening test first. Animals that are ELISA negative are tentatively certified. The ELISA is sensitive, so a negative is reassuring. Animals that are ELISA positive get confirmatory AGID testing. Only animals that test positive on both are declared infected. Series testing: high overall specificity for the positive classification, high overall sensitivity for the negative classification. Scenario B is an active outbreak where we need to find every infected animal as fast as possible before they spread virus further. Here, the critical error is a false negative, missing an infected animal that stays in the herd and infects others. We run ELISA and PCR simultaneously. Any animal that is positive on either test gets isolated immediately. We accept that some of those isolated animals may be false positives. We can sort that out later with confirmatory testing. Speed and sensitivity are the priority. Parallel testing. The key teaching point: there is no universally correct testing strategy. The right strategy depends entirely on what the consequences of each type of error are in your specific situation. Which brings us to our next topic. It's a concept that is critically important for anyone interpreting published test performance data, and it trips up students and clinicians regularly: spectrum bias. Sensitivity and specificity are not universal constants. They were measured in a specific population under specific conditions at a specific point in time. When you apply that test to a different population, the performance may be quite different. The most common pattern is this: a test is validated in a referral or tertiary care population, where truly diseased animals tend to have more severe, classic, and well-established disease, and truly healthy controls tend to be clearly normal. In that population, the test might have excellent sensitivity. It easily distinguishes advanced disease from clear health. But when you apply the same test in a general practice population, where truly diseased animals might have early, mild, or atypical disease, and healthy controls might have other conditions that produce similar signals, the test performs worse. Sensitivity drops because early disease is harder to detect. Specificity may drop because confounding conditions look similar to the target disease. A concrete example: a cardiac troponin assay validated in dogs with severe dilated cardiomyopathy at a cardiology referral center may have different sensitivity when applied to early DCM in a general practice screening program. The disease is the same, but the spectrum of severity is very different. The practical rule is straightforward, but requires discipline. Every time you read a published sensitivity and specificity for a test, ask yourself, was this test validated in a population that looks like my patients? If the answer is no, apply the published numbers with caution and consider that the true performance in your population may be meaningfully different. We've talked abstractly about the trade-off between false positives and false negatives throughout this unit. Now let's be explicit about what those errors actually cost, because this is what should be driving every test strategy decision you make. False positives. Animals or patients classified as diseased when they're truly healthy carry real cost. Unnecessary treatment means financial burden and potential treatment-related harm. A false positive on a reportable disease triggers a regulatory response that disrupts a business. A false positive on a genetic condition in a breeding animal can end that animal's career. A false positive Coggins test triggers federal intervention. These costs are real. False negatives. Animals classified as healthy when they're truly diseased carry a different set of real costs. Delayed treatment in a sick patient. Disease spread when an infected animal isn't identified and isolated. False assurance that leads a producer to commingle a positive animal with a clean herd. Regulatory consequences when a disease is missed in a testing program. Neither error is inherently worse. It entirely depends on the context. And this is the link between all the abstract test performance metrics we've calculated and real-world clinical and epidemiological decision-making. When you're designing a testing strategy or advising a client or a regulatory body on one, your first question should always be, what is the consequence of a false positive in this context? What is the consequence of a false negative? That answer determines whether you need a sensitive test, a specific test, or a series of both. Core dimension of test sequencing that deserves explicit attention: temporal testing, using the timing of tests as part of the strategy. A single test result is a snapshot in time, but disease is a dynamic process. Whether you can detect it depends on where the animal is in the natural history of disease at the moment you test. Test too early and you may miss it entirely, not because the test is bad, but because the signal isn't there yet. This is the window period. The window period is the interval between infection and when a test becomes reliably positive. For antibody-based tests, this is the time it takes the immune system to generate a detectable response. For antigen-based tests, it's the time until antigen load is high enough to trigger the assay. During the window period, a truly infected animal may test negative, a false negative that is not due to test imperfection, but to timing. The practical implication: when the timing of infection is uncertain, a single negative test may not be sufficient. This is why BLV testing protocols for newly purchased cattle recommend testing at the period of purchase and again after a 60-day quarantine period, because an animal infected just before purchase might not yet be detectable at the time of the first test. Similarly, testing a kitten born to an FIV positive queen for FIV antibodies before 6 months of age can give a false positive, not because the kitten is infected, but because maternal antibodies transferred through nursing are cross-reacting with the assay. Retest at 6 months after maternal antibody has waned to get a true reading. Temporal testing is not about distrust of the test. It's about understanding the biology of disease and the biology of immune response, and designing your testing protocol around both. The last concept for this talk is clinical prediction rules and risk scores. These are structured, validated tools that take multiple clinical inputs, signalment, history, exam findings, test results, and combine them into a single probability estimate or risk score. You already use these every day. The ASA physical status classification before anesthesia is a clinical prediction rule. Body condition scoring is a structured measurement tool that serves as a proxy for nutritional status. Welfare scoring systems like FAST combine behavioral and physiological inputs into a structured assessment. In oncology and cardiology, validated survival and mortality scores combine multiple variables into a prognostic probability. What distinguishes a clinical prediction rule from a casual clinical impression is that it was formally derived and validated, meaning someone collected data, built a model, and tested whether the score actually predicts the outcome it claims to predict in a defined population. For day one graduates and practicing clinicians, the expectation is not that you can derive these rules. That's the work of researchers. Your job is to be a smart consumer. That means knowing when a published rule applies to your patient. Specifically, whether your patient resembles the population the rule was developed in. It means recognizing limits. A score developed in a tertiary referral population may not calibrate well in general practice for exactly the same spectrum bias reasons we just discussed. And it means being able to communicate the output clearly. This score puts your animal in the high-risk category, which means approximately 40% of similar animals in the study did not survive to discharge. Clinical prediction rules are not magic. They're formalized probability estimates, and they carry all the same interpretive considerations we've been discussing throughout this unit. Let's close this unit by pulling everything together into a practical decision framework you can actually use. Step 1, estimate your pre-test probability using prevalence, signalment, history, and exam. Everything downstream depends on this. Step 2, identify the consequences of each error type in this specific context. Is a false positive or a false negative more costly? This drives your test strategy. Step 3, decide what you need. Rule out, reach for a sensitive test. Rule in, reach for a specific test. Need both? Use series testing with a sensitive screener followed by a specific confirmatory test. Step 4, check for spectrum bias. Was the test you're planning to use validated in a population that looks like your patient? If not, apply the published numbers with caution. Step 5, is timing an issue? Does the disease have a window period? Does the testing protocol require repeat testing after a quarantine period? Account for biology, not just test performance. Step 6, when the test result comes back, interpret it using either likelihood ratios or predictive values in the context of your pretest probability. Don't read a positive or negative in isolation. Step 7, communicate the result in plain language to your client or your stakeholder, which is the topic of Unit 8. This 7-step framework is not a rigid algorithm. It's a mental checklist that ensures you're not skipping the steps that matter. With practice, it becomes second nature. Here's the summary for this talk and for Unit 2 as a whole. Series testing raises specificity. Require both tests positive to call disease. Parallel testing raises sensitivity. Call disease if either test is positive. Spectrum bias means test performance is population specific. Always ask whether the validation population matches yours. False positives and false negatives have asymmetric cost that context determines. Let those costs drive your strategy. Window periods are biological realities that require temporal testing design. Clinical prediction rules are structured probability tools. Consume them critically. And the 7-step framework ties everything together in a practical approach you can apply in any diagnostic situation. That completes Unit 2. In Unit 3, we shift from diagnostic test interpretation to measures of disease frequency and effect, how we count disease, and how we measure what causes it. Watch the video and work through these scenarios. We'll then go through them together. This question integrates series testing, consequence analysis, spectrum considerations, temporal testing, and the biological complexity of vaccination. A realistic and challenging scenario. Question 1. In a certification program, the primary concern is false negatives. Certifying a PRRSV positive gilt as negative and shipping her to a naive herd where she could introduce the virus and cause a devastating outbreak. Missing one infected animal can cost a farm hundreds of thousands of dollars and years of PRRSV-free status. Therefore, sensitivity is a priority for the initial screening test. That said, false positives are also costly. A producer doesn't want gilts unnecessarily failed out of their breeding program. This points toward a series strategy, sensitive screen, then specific confirmation. Question 2. Use the ELISA first as a screening test. It has 99% sensitivity, making it an excellent tool to catch all animals with any prior exposure to PRRSV. Any ELISA negative animal can be tentatively certified clear. High sensitivity means few false negatives, so a negative is reassuring. Snout. ELISA positive animals proceed to PCR confirmation. The PCR has a 99.5% specificity, making a positive PCR highly meaningful. Spin. Only animals that are ELISA positive and PCR positive would be considered actively infected and excluded from sale. ELISA positive PCR negative animals fall into a gray zone. See question 3. Question 3. PCR negative, ELISA positive most likely indicates past exposure with resolved infection. The animal mounted an antibody response, ELISA positive, but is no longer actively shedding virus, PCR negative. This animal is not currently infectious, but has been exposed. In a strict certification program, this animal would typically be excluded from sale to a PRRSV naive herd, even without active infection, because the antibody positive status indicates the herd has had PRRSV circulation. However, if the destination herd is already PRRSV positive, this animal may be acceptable. The recommendation depends entirely on the destination herd status. MOV PRRSV vaccination 6 weeks prior completely changes the interpretation of ELISA results. Vaccination generates antibody, and ELISA cannot distinguish vaccine-induced antibody from natural infection-induced antibody. Every vaccinated gilt in this herd will likely be ELISA positive, regardless of true infection status. This is a major spectrum bias and misclassification problem. In this context, you must rely on PCR alone as your primary test. PCR detects viral RNA from active infection and does not cross-react with vaccine-induced immunity. You should also consult with a vaccine manufacturer and a swine health specialist, because the timing of testing after MLV vaccination and the specific vaccine strain matter for accurate interpretation. This is a perfect example of why knowing the biological context of a test, not just its sensitivity and specificity, is essential for designing a valid testing program.